Thank you very much for coming. We are very happy, very happy to have Ankur with us today. Ankur Pandya, he's an assistant professor at Harvard School of Public Health. Yes. He has been a very important person in the medical decision-making world, both on the education side and on the research side. And it's awesome we're going to have him somewhere to talk on something that I find is linking the health economics and decision modeling, which is great. And without further ado, please, the floor is yours.
Great, thank you.
Oh, and questions are okay during the talk?
Yeah, and I'll just reserve the right to say, we'll talk about it at the end if I feel like I'm crunched for time. But yeah, please interrupt. So thank you for having me here. It's really fun to be here. I've never actually, I've been to Toronto at SMDM. Okay, but I've never actually been as an adult to Toronto. I don't know. As the title suggests, I'm going to tell two stories today, time permitting. These are two paper performance policies that were evaluated in kind of a big league way. One is a randomized control trial that was done by David Ash and Kevin Bolt from UPenn that was published in JAMA in 2015. And the other evaluation of paper performance program was done by Amy Ryan and some folks. He's at Michigan. He worked with some folks at York evaluating, it was using observational data, but with a diff and diff approach, and they evaluated the impact of the QOF, the UK's paper performance, that was published in The Lancet in 2016. I was fortunate enough to work with both of those authorship groups to then conduct model-based cost-effectiveness analyses of those programs that they evaluated the, let's say, impact of not looking at cost-effectiveness. So that will be the story. We'll kind of walk through each one by one. A little bit of background, very quick background. So there's an intuition around paper performance or financial incentives, which is, we pay people, whether they're physicians or patients or both, we pay them a little extra to do, for them to do the things that we want them to do. Maybe they'll do them more, right? It's kind of like elasticity or dose response. But if you look at the evidence on paper performance in health, it has been mixed. Some of these interventions worked out on the effectiveness side. They hit they improved the quality of care. Others show no effect, and some are actually harmful. So this review is from 2010, but basically the story remains true that sometimes paper performance is effective, but not always. When paper performance is effective, we would like to, from a data cost effectiveness kind of world, we'd like to then know, are those effects that it produces worth the cost it takes to do so? Let's say from a payer perspective. And ideally, the way we like to study this is maybe we start with 1 million people, because this is ideal, right? Randomize them into paper performance, not paper performance, have 50 years of follow-up where we don't lose anybody, and we collect all their deaths, all their non-fatal heart outcomes, and all their costs. And then after 50 years with this kind of perfect study, we can tell our alien overlords whether or not paper performance is cost effective. So the joke here is that no, we can't do this study, right? We could do only kind of, we need modeling, basically. We need modeling to take these short-term impact studies and project out into the future whether the costs that are going in to these paper performance programs, both the incentive payments themselves, which are important from a payer perspective, and also, if you're trying to change behavior, oftentimes this is going to increase utilization, and those could be viewed as added costs. There's probably cost averted too from some, if they prevent costly health events. And then there's the health effects, mortality, morbidity combined with quality adjusted life here. These are not usually coming from these short-term impact trials. So we need modeling to get at the components we need to conduct a cost-effectiveness analysis to say whether or not these system-wide interventions are worth the money, like we do for other things, like for drugs, for screening programs. If you look at the Tufts registry, there are a lot of CEAs, cost-effectiveness analyses, done for those types of services. Relatively less done for systems-level policies. So, arguably, these are just as important, if not more important, in certain policy contexts. Okay, so I will start with this randomized control trial from the UPenn group. This was an important paper. This won the Paper of the Year from Academy Health. That's the kind of umbrella health policy conference or organization in the U.S. A lot of news coverage on this trial, and the starting point for this trial, the inclusion criteria, so to speak, is they were looking at patients who should have been taking cholesterol drugs, statins. Like, these are high-risk patients. They either already had heart disease or they were at very high risk. 10-year Framingham risk score of 20%, that's very high risk. Like in the US, basically 7.5% 10-year risk of having a cardiovascular event is considered, if you're higher than that, you're considered eligible for statins. So this is a high risk group, 20% or more with high cholesterol. The thing is, it's hard to get patients to take their cholesterol medications, even those who are at high risk and heavily indicated. And the kind of like, so I do cardiovascular disease modeling, the kind of general compliance number we throw around is like 50%. 50% of people take their cholesterol medications when they're supposed to take their, when they're indicated. So the golden goose in cardiovascular disease is getting people indicated to take their medications. And that's what this study is getting at. The total N for the trial was 1,500 patients. They had 4 arms in this trial. In one arm, they called patient incentives only. They gave incentives to patients to control their cholesterol. Now, I'll explain how they did that in kind of creative way. But if you're a patient and you're in this trial and you control your LDL, you get paid, essentially. They had another arm called physician-only incentives, where physicians got paid if their patients controlled their cholesterol. And then they had another group called shared incentives, where they kind of halved the level of incentive on both groups, but they had both patients and physicians involved. And there was also a control group in the trial that was not quite usual care, and I'll explain why in a second. This is their table 1. I think the key point is down here at the bottom. Again, these are high-risk patients. And if you look at the percent of patients at baseline taking their cholesterol medications, it's right around that 50% number that I was talking about. So there's kind of, if we can get them to take the medications they're supposed to take, we can really improve health outcomes, and probably, if we just snap our fingers and get them to do it, it would certainly be cost effective. Here, the idea in this pay-for-performance trial is let's throw money at the problem to incentivize these behaviors. And then our question is going to be, is that extra money worth it or not?
Do we know why they don't take them?
It's a great question. Unpacking mechanisms. It's prevention, right? So it's secondary prevention for some of them because they already had a primary event, but it's maybe it's different from like a disease where you have symptoms, right, and you take a medication and the symptoms get alleviated. Here, you don't feel your cholesterol changing, even though it is very important. Some of them, I have a colleague named Lisa Rosenbaum, who's a New England Journal correspondent. She writes a lot of their perspectives. She's also a cardiologist, and she wrote this great essay in 2015, exactly asking that question. Why don't my patients, this is her as a cardiologist, why aren't my patients taking their medicine? And in this kind of qualitative research that she did, she found that for some of these patients, they feel like the medicine taking the pills kind of makes them feel sick or guilty, and they'd rather just not take the pills. And it gets around this broader issue of like medicalization, right, of people without symptoms. And of all that said, most clinical guidelines do say, especially in this high-risk group, like there's very little debate in primary care and cardiology around whether or not these patients specifically should be taking their medicine.
Is it that they can't afford it? Is it that they have side effects?
Oh, so generic statins are very cheap now. It's like less than $40 a year. Back before when they were branded back in the 90s and early 2000s, it was $1,500 a year, like Lipitor, these kinds of things. They made a lot of money for Pfizer and other companies, but now they're generic. Their side effect profile is pretty mild. Like aspirin actually has a worse side effect profile than statins. Cardiologists say, why aren't statins over the counter, or just put them in the water, Previously we did some cost effectiveness work, a 2015 JAMA paper on cost effectiveness, like statin eligibility, and we found for the US it's cost effective to put basically half of adults over the age of 40 on statins. And because they're effective, they're not perfect, but they're effective, side effect profile is pretty minimal, and now they're cheap. Kind of makes sense. The trial itself is interesting, and I'm only going to spend this slide talking about how it's interesting in this way because I actually don't care about these things after this slide. So these guys, Kevin Volpe and David Ash, are very well known for like using behavioral economics and nudge kind of theories. And so they use regret theory and loss aversion as part of the design of this trial. Like for example, patients in the trial where the patients are receiving incentive got a 2-digit number every day that was like randomly generated. And if like they won the lottery, like if both digits matched or if only one digit matched, they would get this notification that is connected to whether or not they took their statin medication the day before. So another innovative part of this trial is they have these like glow cap pills that it's like a smart pill bottle and knows when you open it, and so it sends the information to Big Brother. And like, let's say you're patient and your lottery number gets pulled, but you didn't open your pill bottle the day before. They have this kind of regret theory based notification that was like, oh, you would have won the lottery, you know, for $100 or something, but you didn't open your fill-up. You're not going to get that money. So there's the regret theory thing. The other way, the way the loss aversion kind of worked was you actually didn't win the money. It accrued in this account that you can see. And then you had quarterly checks with your physician to see if your cholesterol is at target. And if it is at target, then you get the money from the account, then you get to keep it. But if it's not, then you don't get that money. So that's another kind of loss aversion. It's like you feel like you had the money, you don't want to lose it. So these guys, you know, it's very psychological. Important to note that even in the control group, they had the GlowCap pills. They had these special pill bottles, and they had their cholesterol checked 4 times during the 12-month trial, which is not usual care, which is important. Yeah, Marie, you have a no. So the maximum payment, if a patient was perfectly compliant, the expected value of their payment is around $1,000 over this year, this 12-month trial. That's about the same level for the physicians. If all their patients were perfect in controlling their cholesterol, the physicians in the physicians only incentive arm would get about $1,000, and it's just halved in the shared incentive group. So that's the maximum on expectation that they could expect to receive. Okay, here are the results from the randomized control trial. It's a 12-month trial, and then they stopped the intervention and still were able to follow the patients for an extra 3 months after the money stopped. So at baseline, everyone's at very high cholesterol, 160, and then they all dropped, even the control group, at 3 months, and that was sustained throughout the duration of the trial, and even when the intervention was stopped, more or less flat lines. A lot of interesting things going on. The main result, like from the upshot from the trial, was that the shared incentives, right, the kind of both patients and physicians getting a little bit less money, that was the only group that was statistically significantly different from control at 12 months and 15 months for their primary outcome, which was LDL control, basically control, like lowering bad cholesterol. The other 2 groups were not statistically significantly different, but like, you might notice the control went down also, right? So the incentives had an effect, but the control group also had the effect. So what's going on there? Possible explanations. Cholesterol is being checked 4 times over the course of this year of this trial. Usual practice is you check once a year for the indicated patients. So that's not usual care. That's something different in the control group. They also had those like electronic pill bottles because they were measuring adherence. That's not usual care with Big Brother kind of watching you. Another kind of regression to the mean, but I don't think so. So in our model-based analysis, we were able to, because we're modeling, right? We created what we call a virtual control group, which is they looked like the other patients at baseline, but then their cholesterol kind of remained the same. In our model, we have this microsimulation model for cardiovascular disease. There is some natural increase in cholesterol on average with aging, but all the groups got that. But we basically tried to remove the trial effect on the virtual control group to the control group.
Excuse me, yeah, I missed it, but these are wide groups. I mean, these are unselected groups of patients, right? In terms of previous cardiac history, risk factors, sex.
It's a randomized control trial.
Population. But what is the population?
Where did they get them from? It was 4 academic medical centers, so they're a little bit lower socioeconomic status. I think you can kind of, I don't know if you can read the table 1, but seems to be probably poorer than average, probably a little bit less educated than average, even though there's variation among that. 80% white. So in terms of like balance among the groups, I think it's pretty good because of randomization. In terms of starting population, probably slightly lower SES because this study was conducted in kind of big academic medical center kind of setting.
Okay. Do you recall how long they had to have been on that statin dose prior to randomization, and the fact that there was not allowed to change the dose of the statins before coming into the trial? Was it like a 6-month period that they had to been on that dose beforehand? Because people coming into a trial, the physicians naturally may say, oh, I'm going to change the dose, and all you're seeing is the therapeutic effect of dose changes prior to the enrollment into the trial.
So coming into the trial, they needed to have basically uncontrolled LDL.
But no change in medication before coming in.
I mean, half of them weren't even taking medication.
Okay, that's different.
And half of them weren't, right? So it's really like, so I think the big challenge is like, get the LDL lower, right? Okay. It's not controlled, we need you to get it lower. I mean, honestly, you could, exercise and diet could be part of this too. The only thing is, in the patient groups, if you're not opening your pill bottle, you might not get that money. But in the physician side, physicians are really good at getting their patients to do diet and exercise. Then they can get their money. Yeah.
Dumb question. So if you have these things which have all of your meds for the day, it wouldn't work because you have to open that bottle. You know, they have these things in which you're on more than one med where you put all of the meds you're taking that day into it.
Yeah.
And that would work because you would open it once a week when you're filling the.
Yeah, if you're using a dose set, you change your method of administration for sure.
Yeah, so this is right. This is part of the intervention. Is this like whatever their cholesterol drugs are in this low cap, and then I guess all their other medications might be in their kind of usual however they usually get it. So it is this kind of, it's also not usual care, right? That's a little weird and different. Yeah. What we did was we used a previously created microsimulation model for cardiovascular disease. This is like a big policy model programmed in C++, based on an R01 that Tom Gaziano, a cardiologist I work with, got from NHLBI, that we had previously put a lot of like methods work into multi-use model. We used this model to then kind of project out cardiovascular disease progression and costs for each of these arms in the trial. Here's a little bit more detail about the model. We call it the CVD predict model, and it has these health states like no cardiovascular disease. And then in yearly cycles, these individuals in the microsimulation can get heart disease or stroke. You can die from that event. You can move on into these so-called chronic disease states. If you start the model with disease, that's where you start. And if you're in one of these chronic states, you have lower utility, a lower quality of life, higher cost, higher increased chance of dying. And this is the model we use to kind of project into the future and basically get the qualities and the costs from. How did we convert the trial results, which was 12-month changes in LDL, I mean 15 months if you believe you should believe the follow-up, into these lifetime qualities. Well, what we did was we took the LDL reductions, here they are in millimole per liter, and let me skip the second bullet for a second. We used relative risks per millimole reductions that came out of previous statin trials. It's a fairly linear relationship. For every millimole per liter reduction in LDL cholesterol, it comes with a relative risk of having heart disease or stroke, like incident heart disease or stroke. And those relative risks are what's driving the changes in the model in terms of people having CVD or not based on the arm they're assigned to. Then there's this question, and this is really, we're going to unpack this a lot later. How long do these LDL reductions last? The trial, the money, was this 12-month trial. They were able to follow the patients for an extra 3 months, and it looked like it remained flat. But how long does that persist? So we had what we call waning in the model, where that benefit is going to deteriorate over time. And in our base case, we picked 10 years, but it's a little bit based on kind of flimsy assumptions, and I'll show a lot of work about that when we get to the results. In terms of costs, so remember the maximum payments on expectation, if everyone's perfect, would be about $1,000 per patient or physician. The observed payments were much lower, so this trial, you didn't get perfect behavior with these incentives. There are some costs to like administering the trial, like the lotteries and these kind of things. They're not related to the trial, I should say, but are related to the intervention should it be scaled up. So we included those costs. We got that from the trial data. There's this increased use of statins based on people who are incentivized to use it, but that's fairly small money because the behavior change wasn't huge and statins are pretty cheap, so we modeled it anyway. And then there's the tests, the extra cholesterol tests and the glow caps, which are not kind of usual care, but the trial control group and all the incentives groups had those at a cost. Our virtual control group did not have these costs, so that'll help the virtual control on the cost dimension when we look at the results. This is my favorite figure one I ever created, which kind of walks through exactly how we modeled. I've been using that screen. Let me help you a little bit, randomize what screen I point to. So we started with a representative U.S. population, the NHANES data set, individual level data, and then we subset that representative group based on the, sorry, it's a touch screen, based on the trial entry criteria, right? Now we have this high-risk group, and we run through like one individual at a time in this micro-simulation, and we had the 5 strategies we're evaluating, and they only differ based on the cost and the LDL reduction. We take those LDL reductions, and here's the CVD predict micro-simulation model. The transitions in red are where those LDL reductions will affect probability, basically that's where the action is happening. That's stopping either primary incidence of heart disease or stroke or secondary. And then the model spits out the qualities and the costs, and that's what ultimately goes into our cost effectiveness analysis, like you would for any other intervention. Okay, here's what we found in our base case, where we had 1 year intervention costs. So the trial, the intervention, like the incentive payments, and I guess the glow caps and everything, those costs only last for 12 months, but the effect waned until 10 years. So a linear waning function, and by 10 years, all the effects are gone across groups. And we have our 5 strategies here. We rank them by total cost, as we are, taught to do. And the virtual control is strongly dominated, patient's incentive strongly dominated, physician incentive weakly dominated, which only leaves then the shared incentive strategy as the most effective, highest cost, and the trial control, which is the least cost, least effective on the efficient frontier, and you get a resulting incremental cost effectiveness ratio of the shared incentives group to the trial control of $60,000 per quality, which in the US is reasonable. Like our thresholds are 100,000 per quality, some people like 50,000 per quality, but somewhere in that kind of reasonable, maybe borderline range. But this is with the 10-year waning assumption, which is a total assumption. I mean, it's mostly an assumption. I'll explain where that came from in a second, but I just want to show you the kind of how these two inputs really affect the results. So if we stuck with the 10-year waning, but we just kept the intervention on like all years, like for their lifetime, they're always this lottery thing, and the payments are happening throughout their lives, and the effect kind of wears off. You see a very different story. The shared incentive strategy then, it went from $60,000 per quality to $580,000 per quality, so no good. And even the virtual control and the trial control kind of flip. So I'll show you, I think I have, I have a heat map that has every level of both of these inputs kind of combined. I'll show you that in a second. Again, this was the biggest question for us. How long do these benefits last? We had to go to like other trials and kind of related, but not exactly the same field to get even a sense. There's this trial published in the New England Journal called the Look Ahead trial this is intensive intervention that then they took off and followed their patients for a long time for diabetes, which is not heart disease, kind of similar, not really. The idea here is that they had very intensive interventions at like years 1 to 4, and then they turned them off and they watched what happened to the patients over time. And so we looked at this panel for like glycolated hemoglobin, measure of blood sugar. They had these intensive trial period, and then they turned it off, and the effects kind of waned at 10 years. And that's what we were hanging our hat on, because there's just nothing we could really do. So not great for base case, but we needed a base case assumption. So that's what makes this figure really important. This is basically a two-way sensitivity analysis for the number of years of intervention costs included, like how long are we paying out the patients and or the physicians, and then how long do these treatment effects last on the vertical axis. And the X here is our base case, which is you pay out for 12 months, you stop the intervention, but the effects kind of slowly persist until year 10, and then they're 0. And you can see like green means cost effective, yellow means kind of borderline, and red here means not cost effective. So this is kind of the most interesting picture out of our model-based analysis. Basically, we ended up concluding was someone should test this out. Someone should test out this shared incentive strategy, let's say, for like 5 years to see if the effects are still going. Because if they last to 5 years, like go to 0 by 5 years, then this is like cost effective, or at least borderline. But if they kind of, if the effects die out by 3 years, then this is, don't scale this up in like a huge way. Yeah.
Isn't like the issue that this is only on people that don't take their medication, and the assumption being that this is going to have no impact on people who are taking their medication? Couldn't there be like a moral hazard where I'm taking my medication, so I'm not eligible for the incentive? And I'm like, well, I'm going to stop taking my medication now because I could get like $100.
So the entry criteria was basically high-risk people who had their cholesterol too high. So there were some like LDL minimums, like 140, which is, even if you're like taking your meds at baseline, like you're not taking them enough, or you're not combining with diet and exercise, or your dosage is wrong, like something is off, and we want to push it down. And so it's a good question about how generalizable that population is. I mean, very prevalent disease, and hypercholesterolemia is very prevalent, but it's not as prevalent as just like above 7.5% risk, which is half of the population. So yeah, it's a good question. Yeah.
So here's the treatment effect. Did you have that sort of decreasing in some kind of exponential fashion down to 0, or did you just switch it off after that time
It
period?
was a linear function,
okay.
which again, that's also a choice. Like we could have modeled different functional forms, but without any data, we're yeah.
I'm pleased for them that they won this big award.
Yeah.
It just seems like this is something that would be very, I mean, many of these patients are on, as Jim already said, like 12 different drugs.
Mm-hmm.
And, you know, to sort of pick one out, like, I mean, thinking about something that's scalable at a population level, like you really want an incentive that will work, can be sustained over time. And I don't know, I mean, they did show a bit of an effect for these combined incentives, but it strikes me as something that doesn't seem like it would be that plausible to actually scale across a whole population and certainly across both comorbid conditions and drugs and things. Like that seems reasonable to you?
I think that's a fair assessment of the idea of the intervention.
Also, it seems awfully fiddly. They've got all these little, you know, I mean, who is at scale going to administer all of these rewards and gambles and what have you? Like, I mean,
if you could, so payers could be interested, right? If like heart disease is like the #1 cause of death and the #1 cause of like cost condition-wise, and kind of statins are cheap. You know, they're giving them out for free, basically. If you could get patients to take these pills, you could really, on a population level, see huge shifts.
no, for sure.
Yeah.
But, I mean, patients also have diabetes. They've also got COPD. They've also got like lots of other things that will kill them. And you know, to sort of pick one, I don't know. Is there going to be an HQO Center for Gambling assessment?
Well, about 3 months, it's not going to be an
Okay.
Yeah.
So no.
The research on it, I'm reminded of one of my favorite pieces of Bad Health Economics, which said that we should encourage smoking because it kills people quickly at about the age they would start collecting their pension.
Yeah.
And therefore it's extremely cost effective.
Yeah.
So if we're talking cost effectiveness, are there a bunch of these patients that we would hope might have a quick heart attack and die and therefore be no burden on the patient?
Well, because statins are so cheap and heart attacks are so expensive, that story doesn't quite fit here. But yes, I mean, you can imagine scenarios where that could play in, but yeah, not here.
To get an idea of what the healthcare resource utilization was secondary to the intervention, in the sense that although you're looking at the LDL, the functional benefit is actually tied to, did you have an MI, did you have stents, bypass surgery, like did they capture that as a function of the trial?
I mean, 12 months, they had some of that, but it wasn't powered for that, right?
Okay.
12 months, so that's why they have LDL as the outcome and not hard outcome, which is why we argued anyway, we need to use our simulation model. That's where all the events are happening. Yeah, and you have to believe this link, right? You have to believe that the LDLs then actually do change the probabilities of having these events in the future. Yeah. So that's the first story.
I'm going to
yes.
Have you tried to look at like uncertainty on the?
Yes. Oh, sorry. We had a PSA. it's not the end of the story, right? So it was a pretty small trial, right? 1,500, so it's like what, like 300 or something in each, or 350 in each arm. So we had individual trial data, which was nice for PSAs because we were able to bootstrap. We didn't have to like work out a distribution there. And then we have other parameters in the model like statin relative risks that we have like probabilistic, second order Monte Carlo, and we combine them all into PSAs. And so you can kind of see, at low willingness to pay, the trial control is the best. And as you're willing to pay more, the shared gets close to 80%. Maybe it's like, what is it, 69%? Yeah, at 100,000. And then the physician's incentives, again, because of this like uncertainty around the point estimate, or around the LDL effects, that pops up, but the patient incentives never do. And that's where the uncertainty is being reflected.
Do you, like throughout discussions with doctors or anything, did you get any kind of pushback on kind of the ethics of doing this? Because we looked into this for asthma, because asthma has the same problem, no one takes their medication. And there was this question of, should we pay people to take their asthma medication? And it was really controversial because a lot of people in the room were like, why are we paying what is essentially bad behavior? Like, do you have people who adhere to their medications, and that's great, and then the people that don't adhere to them, we're now paying them to change this behavior, and they're benefiting from what is essentially a bad behavior. I mean, like, I'm not stating my opinion is, but we found that it was like, it was split 50-50. Some doctors would be like, I don't care if we can stop asthma attacks, so be it. And then the other half were like, no, because what about other diseases, and these people take their medications, why are they not getting paid? And I don't know whether, like, if you were to scale this up to like a policy level, like, you can imagine Fox News being like, paying asthma patients, lazy asthma patients, we're going to pay them, take their medications.
Yeah, and then a lottery. And
I don't know if you had any kind of like,
so I jumped in on this at the end. I was not at the trial design phase. I can imagine the nightmare of the IRBs to get the trial approved. It's a great question. I think the argument is like, this is such a golden goose for CVD, like biggest health condition. How do we get people to take their medications when they're indicated? That might have been like the overriding motivation. But I'm not a ethicist, right? But yeah, it's a great deep issue. So that was same patients. Now we're going to look at this paper performance in the UK on the Quality and Outcomes Framework, which is the largest paper performance program in health. This is a study I did with Andy Ryan. He's an economist at Michigan, but we both overlapped when we were both faculty at Cornell Medicine. And we lived across the hall from each other, actually. We didn't work together. He's an economist, right? And I'm a health decision scientist, modeler, cost technician. But our daughters are the same age, and so like they were the first like friends that they had, and they just walk across the hallway into each other's rooms, and their collaborations, like, they're more productive than we are. But we did do this one project together, and again, this is the world's largest primary care paper performance program. It was enacted in the UK in 2004. It was part of this deal, as I'm told. The story goes. The primary care docs wanted more money, and the National Health Service wanted better quality of care. So they struck this deal, a QOF, where they would link up to 25% of GP pay to performance on quality indicators. This is not $1,000, right? This is serious money on the line for these GPs. Here's the thing. Here's one of the things. The incentives are not evenly distributed across health conditions. Because of the kind of quality measurement, like what's actually in control of the physician versus what's not in control of the physician, most of the points, as they call them, the QOF, are actually related to cardiovascular disease indicators. Like, for example, like you can get up to 15,000 for hitting on CVD indicators and only 1,500 for cancer indicators. Not to say that one disease is more important than the other, but that's just how the quality measurement payment elements of this work. And that's going to kind of play in a little bit. I'll show later. So what Andy and his group did, involved some people from York also, was for their Lancet paper, they did this diff and diff with a synthetic control group. So this is mine as a non-economist, I can't even say the word, econometrician? Yes, as someone who's not that, this is my version of explaining what they did. So you have here, like, the policy changes in 2004, the QOF was enacted. And you have the UK's mortality for QOF-related causes over time. And then you have like these other, how many countries? 20-ish. I guess what are these, like high, medium income countries? And we kind of know, oh, the high income, I guess, just like, we know their mortality over time too. What the synthetic control group does is there's some algorithm that tries to take like pieces of each of these countries to create a synthetic UK. So what if you had a population that was like 11% Chile and like 16% Australian and 25% Ireland? If you took those weighted averages on mortality, you'd see up to the intervention point, you get this very kind of UK-looking kind of synthetic country. And then the way the diff worked was, then after the policy change, they followed that synthetic group and they followed the UK, and they looked to see whether or not the QOF made a difference. None of these other countries had QOF-styled interventions, but again, this is observational data, but used in this kind of quasi-experimental causal estimate kind of way. And here's what they found, that the difference in age-adjusted, so we're talking age-adjusted, sex-adjusted mortality from the mortality related to the conditions they were looking at was in the kind of good direction for the QOF, 3.68 with a 95% CI of plus 0.8 to negative 8.16. So in the conclusion for the Lancet paper, of course, they have to write, QOF does not appear to be, to its alpha level of 0.5 doesn't change mortality. So he published this in 2016, and then I was hanging out with Andy. We met up at the Academy Health Conference, actually, in 2016. We were drinking beers, I think, and I was like, so Andy, you just published this big paper. I know in your discussion you wrote no effect, but like, what do you think the effect is of the QOF? And he said, I think it reduces mortality 3.68 per 100,000 with some uncertainty around it, right? He's not just blindly looking at p-values. So then later that summer, he sent me this email. It was great hanging out, and then he said, what if we did a CEA of the QOF, right? Well, we took that point estimate, and we could do the uncertainty analyses, but like, there's some benefit we're getting from the QOF. And in his email, he had this equation that he made, which is like, just like the years of life saved would be the sum over time across age groups, across sex. And we have the deaths here, and we have like the delta for the QOF, and we multiply it by the life expectancy, and we get this number of like life years saved. He's an economist, right? So he's using all these like summation signs and stuff. I'm a decision scientist, and I was like, yeah, I like this idea, but here's how I would structure it. Here's how I would draw it out. We have a decision problem that the NHS is facing. We can stay with the QOF, which is our status quo policy, or we can stop it. And if we stop it, we'll see some changes in mortality, morbidity, and cost. We can model these out, and then we can do the incremental cost effectiveness analysis to get the ratio to say whether or not stopping it is kind of worth it. Can we save enough money from stopping these incentives to kind of offset the expected loss in health? Because on expectation, this thing is helpful, but there's uncertainty. We started with a quick and dirty model to start, and it didn't get too complicated, but we did end up putting this like front end on the model. So if you go to the paper, this model, the full simulation model in Excel with the user-friendly front end is available as a supplementary file, like the whole thing. And the idea there was like maybe policymakers would actually play around with this model and put in what their estimates were and get like the results. We call them QOFs, effectiveness model. Bad pun. It's a very simple model, like compared to our microsimulation from the first half of the talk. Like these are basically the inputs. Here are the inputs that are coming from Andy's paper. So he had that negative 3.68 mortality reduction. So here's the thing with that mortality reduction. So remember, Andy's paper was age and sex adjusted, like years like 0 to 74. That's where that mortality reduction was coming from. But the QOF, like most of the indicators, are related to like cardiovascular disease. And cardiovascular disease like happens in like older people, right? A certain segment of the population. Like kids aren't contributing to like any mortality difference for like hypertension control. I mean, but probably not. So mathematically, like in order to get this result in everyone, if you believe that the effects are concentrated in this high-risk subgroup, let's say people with prevalent CVD, you'd actually see effective mortality reduction in those folks of 58.93 in order to get this result. So we ended up modeling it both ways. I think we modeled it this way in our base case, but we also like, okay, what if it's just blanket 3.68 applied to everyone? It turns out not to make a huge difference. This is a little bit worse for the QOF because these are older folks, so if you prevented mortality, the massive cost effectiveness, and there's less quality benefit. And then there were some parameters that we couldn't get from A&D study, like non-fatal health events and like extra utilization of healthcare services incentivized by the QOF. So we had to kind of dip into other data sources to kind of approximate for every, let's say, death averted, how many non-fatal deaths would we expect. We got those from some trial data. And there's some other, I think an observational study that looked at the impact of the QOF on drug spending. We kind of had that as like increased utilization as a result of these incentives. Again, not ideal, but in the modeling world, that's what we're left with. So what we ended up doing was just doing a bunch of scenarios, like what if we included the non-fatal outcomes, what if we left them out altogether? And the same thing with the increased drug utilization, what if we included those or left them out altogether? And then there was this other kind of waning element, which was, okay, if we decide to stop the QOF, right, we can assume that all the mortality benefits are like stopped immediately. Or we can have some waning to that benefit, which is like, the GPs are used to practicing this way. It's been around for 7 years. They're kind of used to doing these things. If we stop the incentives, maybe that behavior continues over time. That's another kind of waning. In this case, we kind of had different waning scenarios. And the important thing with this grid is to see that, like, even at the highest willingness to pay for the UK, which is £30,000 per quality, sticking with the QOF was not cost effective, not worth the money. And so that's like the main like top line result here is that stopping the QOF, the money you would save to the NHS outweighs the health you would kind of give up in the base case. And we made a similar kind of looking heat map here for two variables. One was the QOF mortality benefit on the x-axis, and that's our base case result. And here is our incentive payments, annual or total? Annual, on the population level. And our base case is kind of here in this orangey space at 30,000 per quality. So that was our top line result. But there is this kind of, then we're thinking about it like more deeply, like, and this is where having the folks at York kind of on the ground in the UK was kind of useful to hear what was actually on the table for policies. So there's some grumblings in the UK that they're going to get rid of the QOF while we were doing these analyses. And we said, okay. And they said, so they're going to get rid of the QOF potentially, and then they would give that money back. Remember, it's 25% of GP income. They would just give it back to the doctors in the capitation. And if they did that, this is not an incremental cost, right? So contrast that to UK stops the QOF, NHS stops the QOF, and then they just put all that money back into the NHS that they can spend on whatever they want, other health services. Those are incremental costs. That's what we assumed. But if they give all the money back to the doctors, then you're down here. You're like paying nothing for this health. You're like, so we're kind of, okay, that was like the ending point of the study. And then I got this email in January from our program in health policy that Sir Malcolm Grant, who was giving a talk at Harvard, was giving a lunch. Sir Malcolm Grant was the chairman of the National Health Service, also was chancellor, I guess it means like president of University of York. He's giving this talk, and so I was like, I'm definitely going to this talk. So he's there, and he's like very like dashing and like a Downton Abbey kind of character, and gives this amazing talk. But like he doesn't bring up the QOF, and certainly doesn't bring up cost effectiveness during his talk. So right after the talk, I come up to him and I said, we just did the CEA of the QOF, and it really depends on whether or not those costs are incremental. And I very quickly laid out like the NHS takes the money back, then it's not cost effective. If they just give it back to the doctors, then actually keeping the QOF cost effective. And he said, yes, I know exactly what you're talking about. Look on our website, because we're changing our long-term plan for the whole NHS, which he helps kind of spearhead. And he said there's a section in there about what we're going to do with the QOF. And it doesn't have a ton of detail, but it does have this nugget, which is they're going to change the QOF, but not get rid of it entirely. And they're just going to get rid of the least effective indicators. And what I think this means is, talking to, again, our buddies at York, it means there's some indicators in the QOF that 99% of GPs hit, and they just get that money, and it's just kind of like, they're not creating the action we think of the mortality difference. Like, it's just, they're not effective, they're not doing anything. So if they got rid of those kind of least effective indicators, and only kept the indicators that are actually like driving the mortality benefits, then, you know, we might be somewhere down and potentially to the left of what our base case result is. Like, there's going to be less actual money as incremental costs going out to docs. And it depends on if kind of the most effective indicators are actually driving this mortality benefit. Like, so this is where we're kind of left. And so it's a to be continued, I guess. But it's fun because it's an actual real policy decision. There's a lot of money at play. So we'll see. I'm going to New York for 2 months this summer as a visiting fellow. So hopefully we can dig a little deeper into this. And yeah, I think, oh wow, I really went through that one quickly. You know, I think summarizes what I said, that it really depends on whether or not you think the costs are incremental. If they are, then stopping the cost effectiveness grounds could be justified. If they're not, then it really kind of depends on where the health/cost kind of results end up. Okay, yes, I do end this talk with some conceptual slides that kind of can get back to like cost effectiveness analysis and paper performance. So here's how I view paper performance as a decision scientist, cost effectiveness modeler. Like, it starts with some solid clinical evidence, like lowering cholesterol is good in high-risk patients. Like, we know that, right? And then there's some performance measure that, like, so we want patients to like take their statins or something, right? We want to incentivize some behavior. So we throw money at this measure and we'll see some change in short-term outcomes. Maybe it's like the 12-month LDL or something like that. And that's where we can step in with the simulation model, take those changes in short-term outcomes and say, well, what are the lifetime differences in qualities and costs? Because those are, as the first and second panels on CEA will tell us, those are the relevant outcomes that we'll see. And then we can weigh those in our usual cost-effectiveness way and conduct a CEA to see whether or not these extra incentives plus utilization are kind of worth the changes in health that we want. And so that's what the story today was. And then I have this other study that under review, which actually, it uses CEA modeling, but kind of takes a step back in the process that says, when designing these paper performance or financial incentive studies, like, how do we know where to set even the level of incentive? Like, where do they come up with $1,000 in the UPenn study, for example? I have this other idea where we can use simulation modeling to basically come up with those heat maps to give us the upper bounds while designing the paper performance policies before they're enacted. Basically, so decision makers can say, you know, if we expect this much change in behavior, here's the most we should be willing to pay for that. And the levels of incentive should not exceed that, because then, you know, we kind of know it's not going to be cost effective right off the bat. So that's another way we're thinking about combining these two fields. Hopefully I can come back in the future and present that one after it's published. So again, I was really lucky to work with the authors. So the asterisks are people who, from those two studies, like, were part of the original analyses, and then there's other folks who helped out with the modeling. And yeah, thank you.
Thank you very much, Ankur. Any remaining questions? Yes.
For your last point about using the tool to determine something, for that to happen, the paper performance program must have happened for you to collect some data to help you create the model to then adjust the cost, or would you still be able to do it somehow before it even applies that before P?
So if the paper performance was rolled out and we know what the effects were, then we could say whether or not it was worth it. And maybe through the heat maps, kind of see, like, do what if scenarios on incentive level. The idea here is before it's rolled out, so at the design stage, let's model first, just to get a sense of what the upper bound would be for different kind of levels of response. And just to you know, if you think you can get, let's say, you know, 20 points in LDL reduction, but you're not willing to pay more than like $400 to do that, then don't, you know, it's not going to work. Like, we could tell you kind of up front. So it kind of just helps us the upper bound is our idea for that second project. Yeah.
Very interesting talk, but you got very firmly on your face a pair of rose-tinted glasses about statins in general. I mean, I thought we've reached a stage where we realize that they're close to makes no difference to useless in certain populations, and they are useful. And even when they're useful, the NNTs tend to be enormous. Now, you never mentioned NNT.
NNT is baked into a simulation model, right? So, like, underneath the simulation model, we do have like people getting treated, some of whom never have a heart attack, like it would not have changed their life, right, in any way. And then there are those who would, like the 30, like 1 in 30, 1 in 50, whatever number you want to believe, it's kind of baked into the model from the CTT meta-analyses that kind of go into this. So,
but it's the smartest way for people to understand, is this worth my doing or not? And if you have a significant advantage of 58 people on 100,000 with an NNT of 200 to 300 each, it becomes an absurdity at that level.
the NNT is going to be smaller for the high-risk group, right? So it very much depends on what the baseline risk is for NNT, right? So low-risk populations, it could be like 200, 300. For a high-risk population, it could be more like 30 or 20 or something like this, right? And if the intervention is cheap, like statins are now, they're generic, right? And if the side effect profile is kind of minimal, then, you know, what are the balances between qualities and costs? And, you know, that's basically what we try to model out and sort out here. There's extra questions around whether incentives are the right way to do that or not, but so point well taken, but maybe we can catch later. Yeah.
I mean, I think that NNTs for secondary prevention are pretty respectable, I think. But my question, so yeah, many of these high-risk folks.
In this trial, they were like, yeah, this is
but
the third had it, yeah.
So that was great. Thanks. I learned a lot. My question, so you talked about millions of people should maybe be on statins, 50% adherence rate. If we got some sort of intervention that's improved adherence at 20,000 per quality or 50,000 per quality, what's your sense of the total increment in the budget that would require across the millions of Americans or Canadians?
So really, yeah, great. We can almost back calculate it, right?
Yeah, so I was wondering, have you done that?
Oh, no, it would be a big number because the eligible population is so large.
That's my worry, is that it would be a big number.
So you can get into a budgetary impact of affordability.
It depends on whether it's new money or old money that you're working with, right? I mean, it could very well be in the UK, for example, they say this is what a GP makes. We're carving out 25% of that and making that, pay for performance. We're not giving you any new money, but if you want to, keep your old money, or it could be a blended. I think it just depends on whether it's.
That's very rare, right? So in fact, the QOF in the UK was partly politically a mechanism to reduce disparities between specialist physicians and GPs. And
but you could have a combination. But I mean, I think in terms of cost effectiveness, it depends, right? Whether it's new or old.
Yeah, for sure. Like the other cholesterol drug, like PCSK9, right? The price has gone down, but when it was $14,000 a year, the incremental cost effectiveness ratio was like $600,000 per quality.
But in this trial, the ASH trial, it was really new money, right? It wasn't that they took a little bit of money away from the doctor.
ASH trial was new money.
Or a little bit of money away from the patients and said, now you can have some of it back.
Right.
And so my worry with these kinds of things is that the, giant sucking maw of healthcare spending just takes more and more of this money because it is cost effective, but it's not cost saving. We're not spending money on good schools and early childhood education. And so I worry a little bit about that.
So my response there would be enact cost effective stuff and say no to cost ineffective stuff, which in Canada might be different from the US. Like, we don't do the second part, right? Like, we're still spending money on flat of the curve medicine, a lot of bad ICERs, like getting funded. If we take the money out of those things and put it into things that are cost effective, we could see a lot of change. Maybe there's less low-hanging fruit in the UK than in Canada and other places. But.
Another thing, we did some work on accountability and approaches to accountability. And an important variable we found was whether you could control it. So all kinds of really important things were getting lost in the shuffle because they did not want to be held accountable for things they couldn't control. Smoking was one. So it was just disappearing as they went to accountability approaches for public health. They did not want to be held accountable for whether the people in their community smoked. So I think if you're putting the thing forward as a model, it's one thing to look out for is whether some super important things will get left out because the clinicians can't control them.
Yeah, I think that's right. I think that might have been the motivation for the QOF, like why they pick so many CVD indicators as opposed to cancer, because cancer might be more out of their control, whereas like blood pressure and cholesterol, we know there are drugs that can lower those or lifestyles that maybe the physician can help with.
just wondering how much attention also you pay to the structure of the incentive itself, because whether it's directed at patients in terms of the lottery or at practitioners in terms of getting money back, whoever the recipient is will quickly learn how to game it.
Yeah.
So the structure of the incentive is actually part of the effectiveness as well.
Yeah. So for the quaff, if they had 7 years to game it, right? So like this might have been baked in. For the cholesterol one, it was probably maybe too short, or maybe they figured it out. I mean, the cholesterol one though, it is kind of this like, yeah, the goal is to reduce LDL. I don't know if there's a way to like game that, or you open the pill bottle and then go for a run. Yeah, yeah. But I mean, you get.
They have that quarterly mechanism, right? To actually claim your money, your blood test.
I mean,
that's probably why they put
that's
it
the
in.
other part of that whole trial was like maybe it's just checking people's cholesterol 4 times a year is driving. That's why this control group went down. Like that might be the intervention that drives a lot of this, and you don't need to worry about the lotteries and the regret.
We've done that a long time. Monitor.
Yeah, it's monitor, yeah, yeah. But those things, the cholesterol tech, that's also physician time and or lab tests.
All right.
Thanks.
Thank you very much. Thanks, Ankur.